Palak. All good?
Yeah.
Okay, so we're going to talk itch. So this lady has eczema, predominantly in her hands. It's spread more recently, taken urso. She's got an itchy scalp. She's been on antihistamines for eczema, and they don't seem to leave her skin. All of this may be accompanied with the fact I'm perimenopausal and was having hormones prescribed just before all the tests. She's been on heart palpitations, which is very unpleasant. Fatigue and lethargy was told not to take the hormones anymore, but the heart problems are ruled out. I think this has now happened. So anyway, GP has prescribed cholestyramine, which I hope will help this unbearable itch. But when suffering from three conditions, is it possible to know which one is causing the itch?
Gosh, yes. So first of all, I'm sorry that you're going through so much. Who was asked that question sounds like sort of you're going through everything. So my thoughts are with you. Yeah. The first thing is it possible to tell which one's causing which? Yes, but there's an asterisk next to it, which I will come on to. And then secondly, I'm going to ask a very evil question. Does it matter which one's causing it if we find a treatment that works for you and treats your symptoms? The first thing to sort of highlight is that PBC itch mostly, and I say the word mostly because no two people are the same, affects the palms of the hands and soles of the feet. Unlike, for example, eczema, which rarely involves the soles of the feet and the palms. It can affect the hands and feet, but often sort of other elements of them, like the creases in between the fingers and elbows and extensor surfaces are what we call them. So that's the first thing just to highlight. Now, when individuals go through the change, when they go through the menopause, whatever underlying, say, symptoms or chronic conditions they may have, it's not uncommon for those things to be exacerbated. So, for example, if people have joint problems when they undergo the change, having sort of painful knees, painful wrists, painful digits, those features in menopause can be exacerbated, just as an example. So if you've got itch from another condition, then having and then you undergo the menopause, it's not unusual for those features to be exacerbated. Menopause in itself is a less common cause of itching, particularly in those areas I mentioned, the palms and the soles. But of course, what I don't want to do is be very generalizable. We have seen people with PBC who don't itch in those areas, but they itch very much on the scalp and elsewhere. So that's the asterisk point. It is not, can't tell you with 100% confidence. We can offer you some probabilities. Mm-hmm. The cholestyramine is a very safe medication for treating itch associated with PBC and liver disease. Most people who take it tolerate it well, but it does taste sort of quite nasty. Or sort of like thick, like wallpaper paste. It doesn't give a very nice taste. And importantly, if you don't respond to it, because not everybody responds to everything, then it can take about 3 to 4 weeks sometimes to work, and it works better taken regularly. So that's the second thing I'd just like to say. But if you don't respond to it, don't despair. There are a wealth of other medications that are itch specific with a good evidence base in the treatment of itching for associated with PBC. So just to summarize, it's more common to have PBC itch in the palms of your hands and soles of your feet than it is with menopause or eczema. Cholestyramine works well, but it can take a few weeks to work. And lastly, if it doesn't work, please do talk to your consultant about alternatives and give it about 3 to 4 weeks before you write it off completely.
Mm-hmm. Okay, that's brilliant. Thank you. And it's worth saying at this point as well, we do still have a questionnaire up on our website regarding the itch, and that's where some people don't itch at all. Some people itch is treated, and others have difficulty, and others there's just nothing that helps. We want to hear as much information as possible for the doctors and researchers. They need to know all the various aspects of the itch and PBC. So please do go to a questionnaire. It's quite small, it's quite simple, but it would be very, very helpful, wouldn't it, Palak? We need this information coming back to us. So thank you for that. So next we're talking about autoimmune conditions. So with PBC in particular, has research shown any feedback in relation to mast cell activation connected to PBC?
Yes, gosh, that's a very tricky question. So the first thing just to say is that there are some conditions like mastocytosis which can mimic PBC.
Wow.
So the first thing, so mastocytosis is much rarer than PBC. So the first thing I would just want to say is ask your liver consultant or your gastroenterologist, are they completely confident that everything you have is PBC, or is this all mastocytosis? Because we always tell people that if they've got PBC and another condition, then which conditions are they confident that it's two things rather than one, and the same holds true here. So the first thing is just to sort of ask, and there are times, and sadly, and sort of we don't always get it right the first time. I have two people that I've thought have had PBC for a number of years, but they also had features as abnormal liver blood tests in other ways, and were diagnosed with mastocytosis. And then when I performed a liver biopsy on them, it looked all like mastocytosis rather than PBC, and I had to send them to a hematologist, to a blood specialist, because they did not actually have PBC. They actually had mastocytosis. So it's important just be absolutely sure that that it's not all one condition. In terms of have they had any studies? Yes, there have been a number of studies, not just in PBC, but other bile duct problems. We know that if you have mastocytosis, then it can cause the bile ducts, which is a target of injury in PBC, to behave slightly more abnormally, and can lead to sort of scar tissue formation within the liver. So mastocytosis itself can cause liver problems. The short answer is yes. There has been some work on mast cells causing liver scarring in PBC, but just be sure that you have mastocytosis and PBC, or is it just one condition? So ask your liver consultant, how can they be certain?
I don't know if this is part of the same question, and it goes on to say there's another new paragraph, so it may be a different question, but I wonder if it's the same. I've recently been diagnosed with PBC in my female age 53. However, I was also an additional condition of cutaneous mastocytosis. I'm waiting consultation with a hematologist for tests on the systemic mastocytosis. So do you think that's the same question, Palak?
I think so. I think so. Yeah. But I think if you're undergoing investigation for systemic mastocytosis, I mean, I don't advocate for liver biopsies very easily, but if there is any doubt that you have one condition or both conditions, then I would normally have a low threshold for sampling the liver with a very small needle, just to see that we've got the diagnosis right and you have PBC as well as mastocytosis.
Okay, great, thank you. I've last 18 months of experienced increasing episodes of stomach pain, constipation, severe nausea, exhaustion, and an overwhelming feeling of inflammation. My symptoms led to blood tests and a diagnosis in PBC in September 2001. I hope to discuss these ongoing symptoms with both my primary and secondary care professionals. What can Dr. Trivedi tell us about the contribution of the intestinal microbiome and gut barrier to autoimmune diseases such as PBC and perhaps PSC?
Yeah, this is a very nice question. So the first thing that is sort of just to say, for those people who don't know, PSC is primary sclerosing cholangitis, which shares some similarities to PBC, but there are very important differences between them. So just for those people who don't know what PSC is, so in terms of the gut microbiome, we have in the last few years identified many people with PBC, PSC, and a whole host of other autoimmune conditions, whereby the composition of gut bacteria is different. It's less diverse than what we see in people who don't have liver injury. And when we say it's less diverse, we see an enrichment of certain bacteria, certain fungi, certain viruses that we know all of us have, but they seem to be present at heightened numbers in people who have these conditions than we would normally expect. And the second thing is that the gut's immune system reacts in a slightly more abnormal way in PBC and PSC compared to people without liver disease. So there's two things there. You've got high levels of certain types of gut organisms than you should have, and your body reacts in a slightly abnormal way to them. And these particular bacteria and fungi, they release certain chemicals which cause some of the immune cells that are normally restricted to your bowel to travel to your liver. So they continue to cause injury sort of to your liver. And as the person who's asked the question alludes to, they can weaken the barrier, the tight barrier that your gut has, and it accelerates some of the travel, not just of the bugs, but some of the chemicals that they produce, and they cause ongoing liver inflammation. I mean, what people will be glad to hear is that in PBC specifically, when you give ursodeoxycholic acid and people respond to it, some of these changes, quite a lot of these changes, in fact, can reverse back to normal. So we see a beneficial effect from urso, and we're starting to see some beneficial effect from obeticholic acid, whereby this abnormal bacterial composition and the impact of this bacterial composition on the gut barrier is I wouldn't say it's completely reversed, but certainly heads more back to normal following effective medical therapy. So again, to summarize, yes, we do know that the bacterial and fungal composition is less diverse in PBC and PSC. It can cause pathological changes to the gut barrier and to the liver directly, but some of the treatments that we offer you can help restore those imbalances.
Mm-hmm. It's quite complex, the gut and what have you. I'm glad I'm an accountant, not a doctor, because it's quite complicated, isn't it? Yeah. Right, okay. So this person says, I've recently had 2 positive AMA tests along with Raynaud's, which started last year. So there's a good reason to suspect I have PBC. Now, we've got a lack of information here. If whoever typed this up, I think we need to come back with some more answers, but I'll carry on. But there's a long waiting list for NHS assessment. How urgently should I seek a confirmed diagnosis and begin treatment? Should I seek diagnosis and treatment from a private healthcare provider while I wait for an NHS diagnosis? Or would that complicate the test the NHS will carry out? While I wait for a confirmed diagnosis, is there anything I should or should not be doing from a diet lifestyle perspective? Specifically, should I be taking supplements? Before I get you to answer that, Palak, I would like to say to this person, if you're here, it would be important to know what your blood results were, or some of your blood results, because if you have the AMA antibody only, that is a different picture from AMA antibody and raised liver enzymes. Yeah. So I'll hand over to you, Palak. This is a very good question, isn't it?
Yeah, very good question. Yes, absolutely right. That's what I was going to start off with. So if you have abnormal liver blood tests and you have positive AMA, then I agree you should be seen sooner rather than later. And I'm very happy to see you, within 7 days in my clinic if you want to travel to Birmingham. There's absolutely no.
Oh, that's so lovely.
And that's not because I'm afraid that you're in imminent danger in any way, but we do know that early treatment, when it's indicated, is associated with better likelihood of responding to that treatment. So that's why timely treatment is important. If, however, as Collette alludes, your liver blood tests are normal, then there is no urgency for you to be seen in secondary care, so it was by a specialist, and I would just advocate monitoring your liver bloods, say once a year. But of course, you would have obviously had an appointment in that time frame, I would assume. The second thing I just want to highlight is that people who have Raynaud's phenomenon, and so Raynaud's, for those people who don't know, is another autoimmune condition whereby the hands and feet sort of have abnormal reactions, particularly to cold weather. They can become discolored and painful because the blood vessels contract and relax slightly more unusually than they should do. Quite a lot of people with Raynaud's would incidentally have antimitochondrial antibody. So in some studies, it can be as high as 15 to 20%. In our program, it's perhaps slightly less than that. It's more close to 5%. But often that's an incidental finding, but nevertheless, we ask people to monitor their liver bloods. So that's the thing. And lastly, in terms of any diet perspective or any supplements, I wouldn't advocate anything, just a normal, healthy, balanced diet. For now, there is absolutely nothing specifically that I would advise. Be mindful, of course, that some conditions like celiac disease occur in about 6% of people who have PBC, and people who have Raynaud's. So that's the only thing I would also get checked whilst you're waiting, and that's available in every GP practice nationally. So just to see, and if that is negative, so there's no blood evidence of celiac disease, there is no specific diet modification that you would need to do. But if your liver bloods are normal, I wouldn't be too worried at the moment.
But I would invite this person, if they have numbers of the liver enzymes, and if you don't think they're normal, you've been told they're not normal, please do come back to us. And if it's not today with Palak, then Dr. Yeoman will be here next Thursday. So please do, we'll help you all we can. Okay, so diagnosed with PBC October the 29th. I think this is last year reading this, with an ALP of 380. Began also on November the 20th, so it is next year. December, ALP 211. Great. March, ALP 202. August, up to 252. Consultant note to my GP, not to me. Well, you need to sort your consultant out, because ask them in future to let you see the copy of the letter. I only found out when I called the secretary, who sent a screenshot of the bloods. Is this a leap that suggests I'm becoming non-responsive to URSO? Is it safe to wait until next appointment in February, or should I be calling someone sooner?
Okay, that's a very good question. So again, ALP is alkaline phosphatase. It is one of the principal biochemical or blood hallmarks that we monitor when you come to see us in clinic. And we use it to see whether people are responding to urso deoxycholic acid, which is a first-line treatment for PBC. So I suppose, again, just a couple of things I just wanted to just clarify sort of with the, with the person who's asking the question. It's important to know what dosage you're on of URSO, first of all, because URSO is dosed by body weight, and you should be on, roughly 13 to 15 milligrams for every kilogram of body weight. So the first thing is that if you are underdosed and your liver bloods have not improved, or your alkaline phosphatase is going up, then that may be a reason why. And it may be that you started on a low dose to see if you're tolerant to it first, and that dose escalation has not yet happened as it should do. The second thing to see is what your other liver blood tests are also doing in a similar vein. It may be that those are the ones, because ALT values, which is another blood enzyme, bilirubin, are all very important at determining how you respond to URSO. It is not just about one blood test. The last thing I just wanted to sort of just ask the person before I sort of respond with what information we have is that alkaline phosphatase, like any blood marker, can fluctuate. It can sort of go up and down, up and down, up and down. So I wouldn't, within this particular range, say that your bloods have deteriorated. I would say that they are fluctuating sort of above and beyond what the baseline value was. And I would perhaps sort of, it may take a few more months or even a year to see what your bloods are doing. Are they going up? Are they going up and down, up and down? And as I mentioned, seeing what the other liver bloods, are is important, because alkaline phosphatase can come from other sources like bone, from bowel. I don't know the age of this particular individual that they put it on here, but in young women, of course, placenta and other areas. So there are some other things to mention, but I wouldn't be too despondent, because sort of straight away, because it can fluctuate. So I wouldn't, when I say despondent that things are getting worse, I certainly wouldn't say that. I do agree that they require attention, and if this is all liver related and you're on the right dose of URSO, and your bloods are still unchanged, then you would require referral for second line treatment. So that's in addition to URSO adding something in. I certainly wouldn't stop URSO. There is now very good evidence that URSO, no matter what your bloods are doing, improves your long-term survival. So I certainly would not stop at the URSO. But if this is all liver related and there is no other reason for your bloods to sort of remain up like this, I would ask to be referred for second line therapy.
Good. And so I think what Palak is saying, you're looking at trends, aren't you, really? Not just one particular snapshot, it's trends. The body weight thing that Palak raises is really important, because, we've had almost 2 years, really, we've never seen anything like before, and people have gained weight during COVID, our weight changes with age, all sorts of things. So please, we're actually, the Falk Foundation have given us a grant. So we've had a lovely chart laminated. We're sending them out to everybody, Palak, in the country, and we're going to put them online. So we'll be sending you a chart so you can keep an eye on your weight. But don't rely on your specialist all the time. Just if you feel that you put on a bit of weight, check it out. And the diagram's in the box anyway. So I think that's important to say. Thank you, Palak. I'm being prescribed citalopram. I usually take my urso in the morning. Should I take this new medication in the evening or alongside? Does it matter?
Yes, so citalopram, which is a very commonly used sort of medication for anxiety and for mood, it's absolutely fine to take with urso. It doesn't matter what time, how far apart they should be. There is no particular restriction to it. There is another anti-itch medication called Sertraline that some people are offered, and that is the same class as citalopram. So the only thing I would I know it's not being asked, but the only thing I would add is if you have itch symptoms, then instead of citalopram, sometimes we offer sertraline because it's a double whammy. It will work as effectively as citalopram on mood and anxiety, but also it has an added benefit of treating itch in some people. But there's no problem taking them both together.
And I would say to people as well, and I hope you feel this is valid, Palak, that sometimes people are on 5, 6, 7, 8 different types of medication and you get something else and one drops off. If you're ever in any doubt, I always have a chat with your chemist. Chemists are clever people, they come well qualified, they've been at university all these years, they're very smart people. So if in doubt, don't hesitate, and particularly Boots, they'll give you a wee appointment and they'll give you a seat in a private room. So that's always available.
Very good.
Okay, we've got a wee question on the screen there. Palak, I'll read it out for those that can't see it. I've recently developed swelling of my ankles and feeling of tightness in my calves. Can this be related to daily intake of 1250 milligrams of urso, or is this unrelated? And you started taking urso in June.
Yeah. So it's not a common feature of urso, at least in my experience. Ankle swelling. And Collette alluded to generalized, weight gain. That's not just in the COVID era, but urso can cause some people to put on weight. But just in the calves and calf swelling, it's not a common side effect or symptom of it. And I can't recall actually anybody sort of in our program who's reported it. The other things that can cause ankle swelling very commonly, beyond sort of weather changes, the things that we would want to look for or be concerned about, from most serious to perhaps least serious. One is, what are your liver proteins doing? So albumin is a liver protein. So if you've got PBC, I don't know what stage of liver disease yours is at, but if there is any features of advanced disease or the albumin falling, that would be a red flag. So just ask what the albumin is, and equally have a urine test done just to see if you're losing any protein or albumin in your urine, because independent of PBC, if there is any kidney mischief, that can also cause ankle swelling. And the other serious thing to exclude when you've got sort of ankle swelling is if your heart isn't pumping as effectively as it should do. So your heart pumps blood away from your peripheries and other organs around your body, and if your heart is pumping in more of a sluggish way, then that can cause a bit of waterlogging. Now these things are not, they're common sort of as individuals grow older. They are not more common in PBC by any means, but those are just the 3 red flags just to look out for. Low albumin in the context of liver problems, PBC related or otherwise, losing protein or albumin, which sort of in your urine, or your heart not pumping effectively. The most common cause that we see actually is people being on blood pressure medications. So there's a blood pressure medication called amlodipine, and there are other similar medications in its class, felodipine and so on, which are very notorious for causing ankle swelling. It's harmless and fully reversible, but certainly more than 20% of people who are on blood pressure medications of that class can experience ankle swelling. And if you do, it's very simple. You just stop that medication, and other blood pressure medications outside of that class tend to be very effective and don't cause those side effects.
That's quite interesting, because there's another blood pressure medication as well. For example, it can make you cough, and people don't necessarily tie it up if they don't know about it, So Yeah, that's really interesting. Thank you for that. Right, I'm going on to a different device now, so bear with me. My glasses, I'm needing new glasses and they're coming tomorrow, right? So this lady says some strange stuff. Her ALT keeps rising. The ALP has fallen to 800. There's still unexplained inflammation in my liver, and the hepatologist has ordered a second opinion on the biopsy. In March, my ALP was 1404. In late April, I started insulin in early June. The ALP was 880. Now, the HbA1c dropped from 104 to 84 in those 6 weeks. Something has occurred to me. Would insulin have any effect on the ERSO?
No, I wouldn't believe. I don't think it would. I don't think the insulin would have an effect on ERSO. But if you have diabetes, then that is an additional risk factor for your liver bloods being abnormal. Admittedly, the magnitude of abnormality that you're describing would be out of keeping with with fatty liver disease, which is what I'm alluding to. So, fatty liver disease is the commonest cause of abnormal liver bloods in the Western world, and just when people have a bit of fat on the outside, that you can see on the body, they can deposit on other organs like the liver. And so I wouldn't think insulin itself would affect the ERSO, but it may be. But the reason that you're on insulin in diabetes would be sort of that in itself would also cause some liver problems. So I think it's very reasonable to have the liver biopsy looked at by someone with an experienced eye. And if it is all PBC, and if you have got very abnormal blood purely because of PBC, despite being on ERSO, then you would need second-line therapy. And actually, obeticholic acid, which is another medication that we use, is very good at normalizing ALT values. And bezafibrate, which is another sort of medication that we use to treat PBC, is very good at normalizing ALP values. So we have other tools in our armory if it's all PBC. But I think your local team are doing the right thing by getting the biopsy looked at by an external expert.
Yeah, indeed. What's the difference between ERSO tablets and ERSO liquid? Yeah, that's a nice, easy one for you, Palak.
Yeah. So there's no difference in how effectively they work, but there is a difference in tolerance. So some people who don't tolerate capsules or don't want to take capsules by virtue of their race, ethnicity, or religious beliefs because of the gelatin coating, they get on very well with the liquid. I tend to find that people who are more tolerant sort of from the liquid because, sort of than the capsules, particularly when it's split across the day. But there's no difference that we've observed in how well the medications work.
Although we have some people will say to us a particular type of ERSO capsule disagrees with them. And I know James and I were at a conference in Bristol many years ago, and a chemist stood up and explained to us that the plastic around the capsule itself is made of different compounds, and that's what people are more likely to have a problem with, other than the ERSO itself, which is apparently harmless. Yeah, interesting. So what is the fatigue like with PBC? Can it be intermittent, or is there any information on it? Oh, you haven't been on our website then. Listen, I can write a book on fatigue.
No, I mean, fatigue is very challenging. I mean, a lot of people experience fatigue who have PBC, and it can be very debilitating, and it can be very difficult to differentiate from other causes of fatigue. The first thing, just to highlight it, is yes, it affects people in different ways. It can come and go, and there are some people who can, who can run a 5K a day but feel very fatigued very early on as the day wears on, even before lunchtime. And there are some people who work whose fatigue is continuous, whereby they have had to change their working schedules and so on and so forth. So it can be it can be intermittent. It is not something that affects everybody in the same way. A lot of people who experience different types of fatigue, and Collette actually would be perhaps much more of is much more of an expert than I am in this. People will experience fatigue that it can be central, so that's something that's associated with brain fog, or what we in the medical term use the jargon cognitive impairment, whereby they can't process thoughts as quickly as they would be accustomed to, or they can't sort of, and equally they tend to, I wouldn't say forget things, but sort of, forget why they're doing things. And some people have what we call peripheral fatigue, whereby, literally when they're coming back from the shops, they can't physically sort of, have the energy to put their shopping away in the fridge or freezer or in the cupboards. They sort of, we've had a very sad story. I remember this one woman was so weak she couldn't even lift her child up after giving birth, and she fell asleep during things like intercourse, and just physically could not do activities that you would associate with normal life. And that's what we call peripheral fatigue. So there are different types. They're not all the same, and I don't think sort of any of us completely understand why it occurs with such striking variation in people with PBC. But we're working on it. We're trying to help and make it better.
100%, and you're doing fantastic work in it. It's really very exciting. But it's also, fatigue, tiredness, lethargy. You feel like you're being sucked into the pavement. Your legs are like tired, raising your arms, sleepiness, tiredness. I remember Professor Newberger years ago. We shouldn't laugh. He did have hepatitis A, but he said there wasn't a word to describe the fatigue, the lethargy, and everything else. But there's two very important things I would say here, and we've learned this kind of the hard way. Don't go to bed. Just don't go to bed. Go and have a walk in fresh air, and it will perk you up a wee bit. Palak's been involved in amazing research, and so has Newcastle, in relation to movement as medicine, is what we call it. And I can talk some more to you about that, about the fatigue. But the other thing, the important thing to remember, it's not indicative of how advanced your PBC is. People just assume as you go through the years, you get more tired, more tired. It doesn't work like that at all. I mean, I've been diagnosed 27 years and I was tireder then. Just you talking about the baby, my little boys were young and it was so difficult picking them up and doing various things. Whereas now, I go out on my bike and, walk for miles. It's different, but don't sleep. Don't go to bed with it, and give me a ring and let's talk a wee bit more about it, and be mindful of your diet and be mindful of sugary and processed food, because it does fatigue anybody, whether you've got PBC or not. I think it's important to say that, Palak, isn't it?
Yeah, absolutely. So one of the strategies that has been applied for not just PBC fatigue but other types of fatigue and other diseases is graded exercise. And I was a bit saddened to see that in the UK for chronic fatigue syndrome, it's not recommended sort of by NICE anymore, and that's partly because the patient voice from the chronic fatigue syndrome groups said, it's not applicable to everybody, and of course everybody has to be treated as an individual. And I think the way that people were being told about exercise was, go for a run if you're tired. That's not what we're saying. What we're saying is that everybody will have a different approach to it. And if need be, yes, come to a specialist centre and we will develop an exercise program for you.
You raise a fantastic point there, because in another life, I worked for the Tribunal Service, and chronic fatigue, ME, fibromyalgia, all these things were covered at great length. And I was a bit surprised to hear about the NICE, what they had to say. But there's another group of patients that come back and said it's actually scaled exercise, not, as you say, not go out running. It's just go from one lamppost to the next, just small steps, small things, and just building it slowly and with confidence. But I think what was going wrong with the chronic fatigue syndrome was, as you say, they were asked to do too much, too quick, too soon. So never discount the power of your own body and getting oxygen and things moving around. And mentally, it's so good for you as well. You just look at it, to hear different sounds, walking in the rain, the rustle of the leaves and the birds. All these things help. Right, and this one's a bit of a shocker here. I had a biopsy and confirmed it was stage 2 to 3 of PBC, but I'm unsure if that's good or not so good. I get quite frustrated and irritated by this, because this is concern, isn't it?
So you just cut out then for a second, Collette. Can you say that question again? I didn't hear.
Right, sorry, I had a biopsy and confirmed that I was stage 2 to 3 of PBC, but I'm unsure if that's good or not so good.
Okay. So stage 2 to 3. So I mean, there are many different staging systems, should I say, for fibrosis, which is scarring of the liver. Some are out of 6, some are out of 4. And I think sort of with that in mind, it's a bit difficult to answer the question, but if it's say, let's take a worst case scenario, if it's the 4-stage system that the hospital uses where you are, then yes, it's intermediate. So it's neither mild or severe, it's moderate. But the good thing I would say is that there is good evidence that ursodeoxycholic acid slows down the rate at which fibrosis progresses, and in some studies it's even shown to regress the amount of fibrosis. The slightly bigger question, however, is why didn't have a biopsy done? Because in PBC, we don't tend to perform a liver biopsy, certainly not for diagnostic purposes, unless we have doubt about the diagnosis, i.e., is there another entity at play? Is it another type of liver disease that has some features of PBC? And we're trying to differentiate which one is the predominant entity. So I'd be quite keen to know why you had the biopsy in the first place. But I would say yes, it's moderate. It's almost and one of our patients is a very nice lady mechanic who we see sort of in clinic, and she sort of says, it's like she's got stage. She's very happy for me to share the information. She's got stage 2 to 3 out of 4 fibrosis, and she always says, my liver's, it's like 50% brake pads worn. So it doesn't quite need changing yet. Yeah. So, yeah.
Yeah, no, so but any questions that have been answered today, if anybody feels would like a bit more info or a bit more explanation, don't hesitate to give us a ring. Is there a significance on which enzymes are raised? My AP, I think it's meant to be ALP, is usually 127 to 145, but my gamma GT, my GGT is usually 60 to 70.
Yeah. So I mean that is there is increasingly a move in the community to go for as close to normal of blood tests as possible, and the upper limit of normal for ALP in most hospitals in the UK is about 130. There are some hospitals that do a different measurement technique where the upper limit of normal is 105 or 110. But generally speaking, with those bloods, I'd be quite reassured, because that would put you within what we call the biochemical responder category. So even if whether you're on URSO, which I hope you are, or not, those bloods are relatively reassuring. Now, we know that blood tests of that magnitude, if you're, say, an individual say it's in your 60s, 70s or 80s, are a lot more encouraging than if you're somebody who's, say, 20 or 30 with PBC, whereby we would still want to follow you up quite closely, because you've got that many more life years ahead of you, and because those low-level elevations in liver bloods have a higher chance of escaping control when you grow older. So the short answer is, I'm not too concerned about those bloods, no matter what age or sex you are, but I would be keen to see what the other parameters are doing, and I think depending on whether you're on URSO or not, that would determine how closely I would want to follow you up.
Yeah. Okay, reasonable. And I might get pronunciation a wee bit wrong here, so please do forgive me, Palak. I was newly diagnosed with PBC. I also have severe alpha-1 antitrypsin deficiency, antitrypsin deficiency.
And trypsin,
which is another living condition. As far as I know, there's no connection between these two. Do you know if this is correct?
Yes. So alpha-1 antitrypsin deficiency. So your liver and lungs have a condition called have a protein called antitrypsin, and trypsin itself can cause inflammation and scarring within the liver. So antitrypsin, alpha-1 antitrypsin, counteracts that, so it protects your liver. And if you're deficient in antitrypsin, your risk of developing liver problems or lung problems is greater. Most people who have alpha-1 antitrypsin deficiency in adulthood don't tend to run into any problems unless there is another risk factor that would drive liver injury. So, for example, we know that smokers have a high risk of things like COPD or emphysema. And if you have alpha-1 antitrypsin deficiency, the amount that you would have to smoke to get emphysema is much, much smaller than somebody who's got normal antitrypsin levels. And in turn, If somebody's got alpha-1 antitrypsin deficiency that's predominantly affecting their liver, then if they drink even small amounts of alcohol, for just as an example, then the liver is much more likely to progress. And similarly, if your PBC is not under the best control it can be, then there's a higher probability that your liver can deteriorate over time. So the threshold for getting your PBC as close to normal blood test as possible is perhaps even lower, because you've got another fist punching your liver as well as the PBC.
Wow. Okay, I've got another word here I'm not going to pronounce very well. Okay. I have paracentesis weekly.
Yeah.
Doctor wants me to have tips. I hear tips can cause HE. I hope there's no sugar in that, by the way, Palak.
No, it's sugar-free, don't worry.
Does this happen to everyone? If the HE with tips?
No, so paracentesis is drainage of fluid in the abdomen, from the abdomen, should I say, in people who have got liver failure. So I'm very sorry that your liver has got to that stage and you need to have drainage. I mean, the fluid builds up because the pressure in the blood vessels that feed your liver has increased to quite a high level, because your liver either has scarring, cirrhosis, or because there is something like a liver there is something blocking the inflow of it. And by draining the fluid off, we can alleviate your symptoms, but the fluid will recur and can often recur again and again. A TIPS procedure is a very long thing. It's called transjugular intrahepatic portosystemic shunt, and that's, in short, it is a stent or a tube, a small sort of metal tube that bypasses your liver, so the blood flow is no longer obstructed, and it can pass by the liver, go straight into your heart and circulate again, and that way the need for paracentesis goes down. Okay. The person who asked the question asked about this thing called HE, or hepatic encephalopathy. Now that again is a sign of liver failure. It's a sign that your brain is receiving lots of toxins that your liver would ordinarily clear from the body. And when you put a TIPS shunt in, as I mentioned, it's bypassing your liver, so there is a risk that the toxins have a much easier pathway to the brain and can cause this sort of confusional state. It doesn't occur in everybody. It occurs, and when we speak to people about TIPS, we counsel them for about a 25 to 30% risk that may happen. Okay. Everybody that we talk to about TIPS, we also talk to about liver transplantation. And often we say, having this shunt in, it may alleviate your symptoms, but it's not necessarily going to improve your long-term prognosis, but a liver transplant will. So we often talk to people about both of those things and offer both of those things in parallel. And the TIPS is a very good procedure for improving fluid retention in the abdomen or ascites, and mitigating and reducing the need that you would need to have repeated drains. But there is a risk, 25-30% of getting hepatic encephalopathy, and sadly TIPS is not a smoking gun. It's about a 60% chance of success. 40% of people still require paracentesis afterwards. So it's very important that your unit selects people carefully for this. Anybody who's got jaundice, anybody who's got a lot of muscle wastage in their arms and legs, anybody who's got any concerns that the heart may not be pumping effectively, the outcomes following TIPS and the risks of HE are much more negative. So that's why, if it's only fluid retention, but you've got a normal bilirubin, otherwise, the muscle mass is not a concern by your team, and they've evaluated how well your heart's pumping, then I think a TIPS should be safe.
Okay. I can see on the screen here the lady who spoke about the swollen ankles, tightness, calves. She says, I also have alpha-1 antitrypsin deficiency with SZ phenotype. So, this is the thing, when people come and ask you questions, there's other things going on as well, and it's very difficult. It's not always the PBC, or sometimes it's a combination or whatever, because these things.
SZ phenotype means that you've got one of the genes for alpha-1 antitrypsin deficiency, not from one of your parents, but not from the other. So you should still have normal antitrypsin values, or not. I wouldn't say normal, but values enough to protect your liver.
Okay.
Yeah.
Flipping back to the mast cell activation question, the lady has come back, and you talked about cutaneous mastocytosis systemic. So she says, how long will the process take? I feel like gut health has become such a challenge since taking Urso. I'm taking some probiotics as well. Is this helpful or counterproductive?
Okay. So when you say how long will the process take, I wasn't sure what that was alluding.
Well, I think because seeing a hematologist and the tests and what.
Oh, I see a big one. This is probably it's an unfortunate question I can't answer. I can speak for how long it would take here. I mean, here it would take a few weeks, really, but in other places it may take longer, it may take less. I can't really answer that. But if there is any doubt that mastocytosis is involving your liver as well, then a liver biopsy we would normally expect to happen in Birmingham at least within 2 weeks. In terms of probiotics, they do come in various shapes and sizes. I mean, there's not one particular probiotic rule that is generalizable. They can take different things. It's like antibiotics. They can, there are so many different types.
Yeah.
So I probably need to know which probiotic the individual is offering.
Yeah.
There are no probiotics that have been shown to overtly help PBC, neither any probiotics that have been shown to harm people with PBC, but we are still learning a lot about them. And some probiotics are very good for some health conditions, but they may contain some of the bacteria that I was alluding to earlier on in the talk, that drive autoimmunity as well. So it's important to know what you're taking, because there may be a theoretical risk of making your PBC worse. So it would be important to know which one you're on.
Right, okay. This is quite complicated, very important though. Right, I've been taking OCA for 6 months and still taking Urso. Good. Recently, I've had bad constipation, so I was taken off OCA. I also have a feeling of fullness on my right side around the liver area, and also sometimes feel bubbling. I also have a coating of my tongue, which nicely has helped out, but not completely. What questions should I be asking? It's great, that. Good question.
That's good, yeah. So, I'm going to ask this person a question. Has the constipation got better since stopping OCA? That's the first thing. And if not, then I don't think it's the OCA causing the constipation. Now, OCA and Urso are both bile acid drugs. They affect the way that your bile acids are handled, and any medication that does that can affect your digestion. I don't know if this person still has the gallbladder, but if on an ultrasound scan there are stones there, and you feel that your fullness is worse after eating, then then it may be related to your gallbladder. If your liver looks normal on a scan and your gallbladder looks normal on a scan, but you're getting fullness in that side, then something independent of PBC I often ask for is what we call a gallbladder emptying study, just to see if your gallbladder reacts normally after food and drink enter your body. Because some people can have fullness on the right-hand side in the liver area, and if you've still got your gallbladder, you haven't had it removed, it's important just to see whether that's involved. But if your gallbladder looks normal and it works normal, and your liver looks normal and it works normal, then I wouldn't be too concerned about any specific questions.
Okay, great. Now we've come to a bit of a halt with the questions on PBC, which is perfect timing, everybody, because I want now to cover a few minutes on COVID, the vaccine and the booster. And I know that Palak and I have spoken quite a few times in the past about COVID. And may I say, I mean, you have Palak's recovered from COVID, which I'm delighted about. He knows about the vaccines, and he spoke once before about something called an oximeter. But there's a couple of questions that I did ask him offline. I think it's important. People do ask Palak, are they less likely to pick up COVID? They know they can get it when you've been vaccinated. Are they less likely being vaccinated? And will the booster just top that up? So how are we in terms of that? And then if you wouldn't mind, if you could tell us a bit about the oximeter and people who
Yeah.
do catch COVID, and given your personal experience, I know some of your family have suffered with long COVID and what have you. I do feel you but a hepatologist, you know your COVID.
Yeah, I mean, I think we were all forced as a medical profession to become COVID doctors over the last couple of years. Now, we're doing some of the vaccine trials here, so I'm leading on some of the vaccine trials, particularly in people who've got liver problems and who've had liver transplantation. How well do the vaccines work? So the first thing to say is that yes, 2 doses of the vaccine work in reducing the risk that you're going to catch it. Now, the risk of catching it is very low the closer you are to your second dose, and there is a waning effect that we've all now understand around about the 4 to 6 month mark, that particularly sort of with the AstraZeneca vaccine, which is not as potently protective as the Pfizer vaccine or the Moderna vaccine. So we do see a waning effect over on, and that's why the booster program was rolled out. There is now very good real world data from Israel and some data from North America and some data from the UK that is following suit. And what that shows is that when you have your third dose, your booster dose of the COVID vaccine, then the risk of contracting COVID drops significantly. So you're much, much, much less likely to contract COVID if you have a third injection or a booster dose, as we call it. And many vaccines that we have in for other diseases are 3 doses. It's not uncommon. The reason that we have initially a 2-dose vaccine is because we had a global pandemic and there was urgency to get something out there that's been tested and proven to be safe and effective. But if we had time on our hands, we would have a much better knowledge of how many doses we need to give us that long-term protection. What we see with 1 dose of the vaccine is that you get a little bit of protection that wanes, and then you get a boost. You get your second dose, we get much greater protection, and that wanes a lot slower. And now we're giving the third dose where you get even greater levels of protection. And obviously, as the months and years wear on, we'll see how long that lasts. So yes, it does reduce the risk of you contracting it. And by virtue of that, it reduces the risk of you getting sicker, sort of even in the event that you get it. So Collette mentioned that I had COVID. Now, I was very lucky because I had my 2 vaccines, and ironically enough, the day I was due for my booster dose, it was that morning. I had a bit of a sore throat. I did a lateral flow test. I went for a run. I came back and my lateral flow was positive, and I didn't believe it. So I felt I didn't come into contact with anybody, thankfully, but I was very grateful that and we do lateral flow tests twice a week as NHS workers anyway. So I was very lucky that we that I didn't come into contact with anyone, and I had a day where I felt a bit under the weather. My smell went, but then very quickly returned. My taste went and very quickly returned. So the sum total of days I was ill or symptomatic was probably 2 days. And when I say ill, I didn't have the fatigue with it, which I was very grateful for. I had a very mild fever, but I could still sort of do other things. And my children had it very bad. My 5-year-old had a fever of 40 degrees for 6 days and needed pediatricians and things sort of to get involved because he couldn't recognize people and all sorts. So it does affect people differently. And for those of you, the reason I say that is not to gain any form of sympathy, but just to highlight that it is important to particularly for those people who are not old enough to get vaccinated, for us to ensure that we're vaccinated as adults and get our booster doses when we're invited to get them, because it reduces the chances of family members and younger people or those who can't have vaccines contracting it. So I felt very guilty that I was I brought it home and gave it to him, but the booster doses do work, and they work very well.
How quickly did the booster dose, how long after you receiving it does it start to take effect, do you think?
So normally, the curves start to separate around sort of 2 weeks afterwards. So about 10 to 14 days after the booster dose, we start to see a very clear separation of a very low risk of contracting COVID group and a very high risk of contracting COVID group. It will be a lot harder as time goes on to pick out these differences, because some people may have got COVID recovered from it without even knowing, or
Yeah,
got
sure.
COVID with mild symptoms after a second dose. And we know that if you've had COVID and then got vaccinated, you're super protected and for a longer time. So for that, it'll get more and more difficult when we start to see some breakthrough infections. But to answer the question, it not only protects against contracting infection, but also against, if you do get it and you're unlucky enough to get it, for that becoming severe disease. And that is published data in very high quality.
And we're going to mention oximeter or oximeter, as they call this. Is
So we learned very early on in the pandemic which people, when they contract COVID, are going to be at risk of coming to hospital, requiring intensive care, and sadly, leaving this world. And we hear a lot about things like age, about people who are overweight, people who've got other healthcare conditions, but irrespective of whether you fall in that group or not, it's how do you look after yourself when you've got COVID? And two very simple things that I've been preaching very early on, and we did them at home, and I advise my in-laws, my neighbors, my loved ones to all do it, and it saved and it has saved some lives, I'm glad to say, is that if you contract COVID, some people, when their oxygen levels drop, don't realize it. You get this, what we call hypoxic unawareness. You just don't know your oxygen levels are low until they get very low. So on Amazon or from Boots or from or from Superdrug or from any wherever you like to shop that sells sort of medicines, ask your chemist for what we call a pulse oximeter. They do cost, the price has gone up sadly, but they range from about £9 to more than £20. And it's just a little finger probe that you put on, and it tells you what oxygen levels you have in your blood. And normally, when we had COVID at home, we would check ourselves about 2 to 3 times a day, and if your saturations are falling, so get below 94 and consistently either below that level or go up, and that is a red flag sign, and certainly that would require calling an ambulance to be taken into hospital. The second thing is buy yourself a thermometer, and if your fever is consistently 38.5 or above for 5 or more days, that again is a red flag sign where we would want to see you in hospital, because that's a group of individuals that run into problems with what we call pneumonia and pneumonitis. So those two things, of course, if you're concerned about other issues or you have other symptoms that you're concerned about, please call 999. But those two things that, if you measure your saturations, if they drop, 94 or below, come into hospital. If your fever is persisting for more than 4 or 5 days, then please do come into hospital, because we are here to help, and we know that early intervention will work. I will say one final thing, just on that, which I haven't mentioned before. As of today, the UK, or tomorrow, I think, the UK will have a new drug called molnupiravir, I can't pronounce it properly, which has been shown to reduce the risk of severe COVID by 50%. So those people who contract COVID, if you receive that antiviral treatment within the first 5 days, your risks of needing hospital admission are halved. It will only be available in the first instance to those people who are in high risk groups by virtue of age, body mass index, and other comorbidities, including diabetes and obesity. But it is another tool that we have. So it's important just to if you do get COVID, just to ask about that from your GP. And it's most effective if given within 5 days of a positive test.
Is that for PBC people as well?
I don't think it'll be for everybody with PBC.
But maybe in the later stage, or
those people who I forgot. They haven't told us what the age cutoff is, whether it's going to be 50, 60, or 65.
Yeah.
But a large proportion of people who will be in that age group will get it from that age. Some people who have got advanced liver disease and cirrhosis, or who have had a transplant for PBC, yes, they will also be given access to it as well. But we are still waiting for information about it. Yeah.
Fantastic, absolutely fantastic. I'm going to tell everybody that Palak's talk about the oximeter, the little thing, your finger just goes into it. He did save my friend's life. My friend keeps saying, I hope you've told that nice young doctor. Yes, I have. He did save my friend's life. He absolutely did. Now, I've got a couple of comments here. Interesting rebiotic, says Margaret. Would it be possible at some point in future example on the Bear Factor, the website, to list the safe ones and the ones that may possibly not be. Thank you. Apologies if this has been addressed, if this has been addressed, as I'm going to say, the part of today's session. You can watch this again, Margaret. Yeah. But the impression I got, Palak, was safe and non-safe, and it all depends on an awful lot of things about ourselves individually.
Yeah. It does. I mean, I'm very happy to sort of discuss it. The challenge is that there are so many probiotics out there. It's a very tall task to cover all of them. I can perhaps sort of just mention some of the ones that, I mean, the most important thing is none of them have been shown to cause harm, neither be of benefit in people with PBC, but there are one or two that contain certain bacteria which in people with autoimmune diseases are already present in high numbers. So there is a theoretical concern, but we don't yet know whether that means it's unsafe and whether the other bacteria in that cocktail sort of counteract that. So I think I'm very happy. I think we should do one, something like that for bare fact. It may just be a little bit too early based on the knowledge that we've got right now.
So that's for the future after my retirement.
Well, up to that. But if there is a particular probiotic that somebody wants to ask a question about, that may be more easier to sort of do and more correct to do.
Yeah, let's just last comment. Very grateful to receive my COVID vaccine booster. Do you think we shall all need an annual vaccination in future? Well, that's what Palak was saying. We don't know. You're welcome, Margaret. We don't know, but it's watch this space. This medication, I saw it on the BBC Newsflash today. It was fantastic. Do you know, Palak, you've answered lots and lots of questions, and you do it in such a way that's so easy to understand. I can't thank you enough. I'm glad you and the family are all well. Did your wife get COVID, by the way?
No. So I think she had it last year before testing was commonplace, and then obviously she had 2 vaccines. So but by some godly miracle, she escaped it. She was nursing.
Oh, that's fantastic. Palak, thank you so much for giving us your time. I know things aren't easy working in the NHS and all the extra demands that are made of you. We're really grateful. Here's Alan to say to you, thank you everybody for your questions as well.
Well, thank you to you both. Another fantastically interesting session. Honestly, it's absolutely wonderful. But basically, thanks to everybody who joined in today. And I think, Collette, the next one, next Thursday, if I can say, I think it's a 6 o'clock at night one, because our guest medic, Dr. Andrew Yeoman, is unable to make an afternoon session. So again, Palak, thank you very much for your time. It's very much appreciated. Collette, we'll speak soon.
We will.
Thanks very much to everybody who did that.
Thank you.
Thank you.
Bye,
I'm just going to close this down, okay? Thank you.
Bye-bye.
Bye.
Bye.